SelectCCS is a test that allows us to look at the chromosomes of each embryo prior to its being transferred. It stands for complete chromosome screening. It is a new thing in reproductive endocrinology and infertility whose purpose is to keep us from transferring embryos that aren't capable of producing babies. We expect that to do two things: increase the pregnancy rates per transfer and decrease the miscarriage rates.
SelectCCS is the brand for RMA New Jersey. To our knowledge, it's the only platform that's been validated through FDA style tests before being put into use.
PGD in probably 10 years ago was looking at 10 to 12 of the most common genetic defects in embryos that kept them from implanting. However, the biopsies were done on day 3, and what we discovered was the biopsy at that earliest stage decreased the implantation rate by about 40%, whether or not it was genetically normal or abnormal. With complete chromosome screening, the biopsies done on day 5, where there's been some differentiation of the cells. We have cells that are embryonic, we have cells that are destined to become placenta called trophectoderm, but they have the same chromosomes. So the idea is, by biopsying something that's not part of the embryo, we've decreased the morbidity to the embryo from a day 3 biopsy and increased implantation and made it more accurate, because with CCS we look at all 23 pairs of chromosomes.
Now what we look at with PGD is actually a diagnosis. The difference in the S and the D: S is screening, that's just looking at the entire array of chromosomes, making sure there's the right number. The diagnosis is if you have cystic fibrosis. If you have pretty much any single gene defect that they can test for, they can develop probes for, and we can test for that as well. And some of the patients that we have actually use both. We've had a patient with cystic fibrosis that also wanted to have their chromosomes screened. So you can do both of those things at the same time. Up until relatively recently, the standard to biopsy embryos was to go in on day 3, where they only have about 6 or 8 cells, and you take 1 cell out, continue to culture the embryo, you send the cell, have it tested for whether it's PGD, PGS, whatever. And on top of not being very accurate, doing the biopsies at day 3 can do considerable damage, because you're taking 20% of the embryo, almost, not quite, but 15 to 20% of the embryo's mass you're taking at a time when it hasn't differentiated. So it's a lot more traumatic, and it was found to be not very good at all. It was actually detrimental. Going now, what we do is actually take a small laser under the microscope and snip 3 or 4 cells off of the trophectoderm. It's the outer part of the embryo, it's the part that makes the placenta, and they're very resilient. We snip them off, we take the embryos, we freeze them, and if I don't have them frozen within about an hour, they're already growing back. So that hole seals right back up very quickly. So no, it does very little, if any, damage to the embryo then. And the other reason that it gives us a better outcome is because we're taking more than 1 cell. Sometimes if you only take 1 cell, if you don't get everything just right, you don't get enough DNA to read. So by taking 3 or 4 cells, we get enough to amplify, we get enough to read and get a more accurate reading.
Companies that are doing that, we think RMA of New Jersey has the most accurate platform, and their accuracy is proposed to be 98.6%. Several months ago, Dr. Cochran and I were invited to a meeting whose purpose was to let them present some data to us, and this was looking at their validation data and the number of cases they'd completed, and looking at the accuracy. And we were asked to attend that meeting for the purpose of participating in their ongoing marketing of this SelectCCS. It uses a different form of DNA growth than most of the other things that are available. And they've had 7 publications in our peer-reviewed journals and over 2,000 patients that have been screened, and by far theirs has proved to be the most accurate that's available in the United States. $3,000 per couple. That goes to a foundation established by Reproductive Medicine Associates of New Jersey that goes straight into research and development. It pays salaries for scientists, so they're not taking vacations and buying new cars from that money. If you have no euploid embryos to transfer, it appears to be a wash. That's about $3,000 from that point on. If you have a pregnancy and a miscarriage, not only is that $3,000 spent, but it takes you out of the loop for about 4 to 6 months while you get over the hormone changes associated with miscarriage to be able to go again. So it does add, but it increases the chances of pregnancy rate to somewhere in the neighborhood of 65% for a single embryo. It's interesting to historically take a look at where we've come from. When we started, if somebody had a pregnancy rate of 20%, it was outstanding. Mother Nature does about 20%, so we were comparable with Mother Nature. As we've improved and learned more about the process, the pregnancy rates have continued to go up. In the last 3 years, they've plateaued nationwide at about 40%. You can see some variation a little above or a little below, but it's not the giant increases. We have been transferring 2 embryos for 10 years, if you're under 40, without special indications. And as the pregnancy rate went up, the twin rate went up. The biggest danger to IVF pregnancies today are multiples. And although people don't off the bat think of twins as a negative outcome, both mother and babies are at much greater risk for morbidity and mortality if there are 2 babies as opposed to 1. The difficulties prior to CCS was getting people to agree to transfer 1 embryo, because the pregnancy rate was lower if you transferred 1 morphologically normal embryo as opposed to 2 morphologically normal embryos. With CCS, transferring 1 screened embryo now has a higher pregnancy rate than 2 morphologically perfect unscreened embryos, and people can accept that.
For a failed IVF cycle is because of bad genetics in the embryo, and that goes back to bad genetics in the eggs. When a woman's born, only about 1 out of every 3 of her eggs are genetically normal or euploid at that stage, and that number decreases as the woman ages, which by the time she's 40, it's about 1 in 10. So by screening these, we are able to prevent transferring embryos that aren't going to make babies. If we transfer 1 euploid embryo, we get equal to or better success than transferring 2 that aren't screened, because we don't know if they're euploid. The aneuploid embryos can fertilize, obviously divide, grow, they can implant, they can go all the way to 8 to 10 weeks, and then you miscarry. And so this helps eliminate that as well. And that's kind of, to me, the twofold. I think, the big push for us now is to reduce twins, because our twin rate has gone up as we've gotten better, and now our governing bodies are starting to suggest maybe we count twins as a negative outcome, because we have to report our statistics to the federal government. And so some people transfer more embryos to make sure their success rates are higher. We think that transferring 1 embryo is the way to go if we can maintain. We think it's a better outcome for the patient. But on top of reducing the twins, we also think, particularly Dr. Webster and I, that reducing the chances of miscarriages, the way that this does, is just as important. Because that takes a financial but a very emotional toll on patients.